Is an aggressive, angry, violent man.
That statement by Robert L. Saddoff keynotes this week's probe of a dangerous myth, the so-called typical rapist, on Audio Digest Psychiatry, Volume 5, Number 16, for the week of August 23, 1976. In this panel discussion, taken from the 1976 meeting of the American Psychiatric Association and geared to identifying and controlling the rapist, Dr. Saddoff describes the current legal view of the rapist. Richard T. Rada provides a new psychological classification. Parky Dietz offers the sociologist view, and Gene G. Abel outlines his street program of treatment. Leading off, Dr. Rada underscores his concern with the problem.
Rape is the fastest growing crime of violence in the United States. National figures for the Uniform Crime Statistics of the federal government shows that the number of rapes is approximately 47 per 100,000 female inhabitants. If you take a look at Albequerque, where I come from, the yearly average is approximately 114, or 3 times the national average, and it partly accounts for why many of us from that area are particularly concerned about the problem of rape. In talking about the psychology of rape, in the literature and amongst clinicians, there are basically 2 major issues. Is rape primarily a sexual offense? Is rape an aggressive offense? Now, I think that recently there has been definitely a trend toward looking at rape not as a crime of sexuality, but primarily as a crime of aggression, or at least some combination of these 2 factors, depending upon how one puts those together. Obviously, most of our experience is based on incarcerated rapists, and we have to always be cautious about our generalizations. But in my experience, I've been impressed with the aggressive component, and I'm not just talking now about the physical meanness component of sexuality of the rapist. What I'm talking about here is the desire for control, domination, and power that one sees within the personality of the rapist, especially vis-a-vis the female in the event of rape, and also that this is not a crime of unbridled sexuality. From a clinical standpoint, one interesting facet is the obsessionalism which one sees, and if one is psychoanalytically oriented, you can look at this in terms of the dominant-submission conflicts which rapists also have. And very often, in my experience, you can talk to a rapist about the event of rape, and he can go into exquisite detail about all of the ritualistic aspects prior to and leading up to the rape, and then may very casually say, and then I raped her, or then I had sexual intercourse with her, and go right on. For the observer, you feel like you want to stop him and say, but this is apparently what this was all leading up to, and then you just kind of dismiss that. One is impressed with the fact that all of the other things, the ritualism and the obsessionalism that they can go through in describing this particular act. Now, sexuality plays a much smaller role than is supposed, except for one facet, I believe, and that is that there has been frequently stated in the literature that the sex offenders do not tend to cross lines. In other words, if you're a voyeur, you're a voyeur. If you're an exhibitionist, you're an exhibitionist. And although that is probably true for certain types of sex offenders, characterologically, when you examine and when you have contact with rapists, what you see is a tremendous amount of prior behavior that relates to sexual deviations. And so many rapists have had a history of voyeurism, exhibitionism. Not very many, granted, have had episodes of pedophilia, but you do see that. And the reason I'm bringing this up is because it's frequently stated that one doesn't need to worry about the aggressiveness of the exhibitionist or the voyeur, but the problem there is, although these may be characterologically passive people, if you're talking about the pure voyeur, you cannot be certain whether or not you are dealing with someone who is a potential rapist. Now, go on to the classification of the rapist. There are a number of models that have been suggested. Garofalo and his group have talked about motivation and aim. Others have talked about a dynamic theory, including categories of displaced rape, compensating rape, self-satisfying rape, and sadistic rape, each with a different dynamic motivation. Menachem Amir, has talked about role theory, in which he basically suggests that rape fulfills certain role expectations. Gene Abel operationally has defined 3 categories in which he places rapists and feels that these categories are particularly useful in terms of treatment approaches, and he'll be discussing that. From my standpoint as a clinician, and especially in terms of dealing with the courts in this, I have devised 5 simple classifications of the rapist. And the first is the psychotic rapist, who in my experience is very often the most bizarre and oftentimes the cruelest and the most dangerous in terms of his impulsive raping. The second group is the severe situational reaction. And this is the person who is very often neurotically depressed. If you talk to him, he's had a very severe downhill course over the last 6 months in his life, with many of the unfortunate mishaps that can characterize life, but he is taking it particularly badly, and very often just prior to the event of rape, some severe situational stress was added. His wife left him, he lost his job, whatever. The masculine identity group includes that group that has a great deal of machismo. In our area of the country where we have a heavy Chicano population, we see this kind of rapist, and oftentimes these types will get together in group rapes. There are also, of course, those who are fending off homosexual concerns, and also the classification which I would call the pseudo-homosexual. Then there is the sadistic rapist, but this group, frankly, in my experience, is a very small group. And finally, there are the criminal sociopaths. This is the group that, frankly, might rape one day, steal the next day, commit pedophilia the following day. And again, in my experience, this is a group which usually had more sexuality involved in their rape. In other words, they rape because they do want to have the sexual event rather than just the aggressive event. And they also, paradoxically, are usually more clever because they're better criminals. And so this is a group that I think might be more likely to get away with it. In our experience in Albequerque, in other areas where we've been dealing with criminal offenders, we have found this group to comprise people who don't get caught. And subsequently, we have learned some things about rape from those who have never been caught but have been brought to trial for other types of offenses. And then in the course of therapy, they reveal to us that they have been rapists in the past. I'm going to stop there and turn the podium over to Park Dietz.
It's difficult to speak about the sociology of the rapist, since sociology inherently involves the study of more than one individual at a time. But there are a few things that sociology, I think, can contribute to the study of individual rapists. And I think it's interesting that approaching the literature from the standpoint of a sociologist, one comes up with a typology that doesn't differ significantly from that Dietz just presented. In particular, looking at the background variables of rapists who are convicted for various charges of rape and different degrees, looking at the attitudes of the individuals who are so convicted, and looking at the social interaction between victim and offender, one is struck by 3 predominant patterns that seem to distinguish different groups of rapists. First, the group of statutory rapists. Second, the aggressive rapists. And thirdly, violent sexual assaultists. Now, the statutory rapists, of course, are for the most part people who have been involved in heterosexual relations with a woman who is under the age of consent in the particular jurisdiction. And most of the individuals who are convicted of statutory rape don't differ from the conventional population in terms of their background variables, family life, education, socioeconomic status. They simply are people who are involved in what is generally considered acceptable behavior, but who are caught under circumstances in which they have broken a formal law by being involved sexually with one who is under the age of consent. People who are so convicted and who are adjudicated for it seem not to have their lives markedly altered by that kind of adjudication and sentencing. And even if they serve prison sentences, the evidence that's available, which is limited, indicates that they don't become criminals and involved in many other sorts of criminal activities as a result of having undergone that process. The second group of aggressive rapists involves individuals who are convicted of forcible rape and whose crimes vary from the typical college date in which a male will use excessive force in gaining sexual entry with his date to ambush sorts of rapes in which someone will attack a stranger but has in mind primarily sexual interest. Now, there's no way that we can look back at the cases and be sure of that, and sociologists aren't prone to try to read people's minds in particular. However, there does seem to be a group of people whose rapes are sexually oriented. Sex seems to be the major proponent of it. They don't differ markedly from other individuals in their background variables or in their attitudes, but they have been convicted of an act which involves the use of force in gaining sexual access. Now, that distinguishes them from the group of violent sexual assaultists, because in these instances it doesn't always seem that the sexual orientation is the focus of the crime, and much more frequently it appears that violence and aggression is the focus, and that expression of hostility toward women is much more the nature of the act than sex per se. And here there is a difference in background variables. For people who are involved in violent sexual assaults, where the violence is on the order of attempts at asphyxiation or actual beatings or the use of a lethal weapon, in these instances the people do come from a different kind of social background. There are differences in their families of origin, and they seem to have markedly different attitudes towards what is acceptable behavior. With the group of aggressive rapists who do not use lethal weapons or beat their victims, the only attitudinal difference that clearly emerges is a rather insensitive view of the feelings of others. And in particular, the view toward women of the average aggressive rapist is very much like the view that's stereotypically portrayed for working class Americans. On that note, I think that from the standpoint of sociology, the major hope for prevention of sexual assaults and of rape lies in the realm of efforts to cease and desist in our perpetual display of violence in association with sexuality. That certainly pervades the mass media, and it probably contributes to the association that many men in our society hold of sex being related to violence. And I think that the nature of rape being covert as it is and usually hidden from the view of others, it would be very hard to design true preventive measures that don't involve somehow changing the behavior of victims and offenders. It would be nice if we could have some environmental modifications that would do that. I think that's where we should always look for preventive measures. But I think rape being what it is, we need to try to do something about behavior. And I think that societal widespread attitudes concerning the linking of sexuality and aggression are the place that we have to focus our attention there. One other thing that is appropriate to comment about from the standpoint of sociology is group rape. And I think that that's been very largely ignored. It certainly comprises a significant proportion of all rapes. For example, in the study by Amir, there were 646 cases of forcible rape investigated that were known to the Philadelphia police in 1958 and 1960. Of these 646 cases, 370 involved a single offender. In 105 cases, there was a pair of offenders, and in 171, more than two offenders. Thus, about 43% of the Philadelphia rapes involved more than one offender. If one looks at the number of rapists involved, in the same study there were 1,292 offenders. 370 of them had been involved in single rapes, 210 in pair rapes, and 712 in group rapes. Thus, 71% of the reported forcible rapists in Philadelphia during the years investigated were perpetrators of group rape. Now, in the process of group rape, one can hardly imagine that typical processes of social interaction, typical patterns of influence between individuals apply. There have not been many studies of what occurs in group rape, and one paper that does appear in the literature by Blanchard that looks at two group rapes and investigates what occurred and tries to observe the interaction of these groups shows that the leader in a group rape seems to have a key role in perpetuating the sexual aspect of the activity. I think it's fair to say that typically there's a group of young males, frequently adolescents, who are involved in delinquent activities repeatedly, are well known to one another, are friends, and that the leader in the group is the one who canalizes their activity into something that culminates in rape rather than in the usual acts of vandalism. Group rape provides a setting for the study of small group process, which would be of great interest to social psychologists working in institutions. If it were possible to observe the interaction of the groups who have been involved in rapes, I think we could learn a great deal about what processes facilitate the occurrence of rape in these settings.
Thank you, Park. Gene? Gene will be discussing the treatment of the rapist.
I'm going to talk about an outpatient street program that we've been developing over the last 10 years, primarily treating individuals off the street who are voluntarily seeking some type of treatment for their proclivity to rape. My orientation is very behavioral, and I'm not going into the background of how we arrived at this orientation, but I'd like to summarize what are the major components of treatment of rapists. And because I think these treatments are available now, and I think they've been available for quite some time. We just haven't been applying them to rapists. We've assumed that rapists are different than other types of individuals having sexual problems. We have a gadget now called a penile transducer that fits around the individual's penis, and you can present the rapist descriptions of rape or a sadistic rape, or really any type of content that you would like, and you'll find that rapists, as opposed to non-rapists, when you plot out their erection response, will get erection responses quantifiable on a polygraph. These responses occur to rape cues. The relevance of that is that we now have, in the last couple of years, a means of objectifying an individual's response to rape. And if we have that, we then have a measure of how he's proceeding in treatment, because we have a number of treatments available that decrease an individual's arousal to rape cues. I'll mention just a few of those. We have covert sensitization. We can use biofeedback procedures with this gadget to reduce erection responses, electrical aversion, odor aversion. We have a number of aversive techniques that say an individual may start out treatment with 100% of erection responses to rape cues, and then we can actually implement a treatment and watch the decay in the individual's response to rape cues. And that would be one criteria of that particular component of treatment. A second component of treatment then, not reduction of arousal to rape, but increasing arousal to non-rape sexual cues. That's another component. Many years we thought that that's how you define deviants, by their deviant arousal, but that is not necessarily the case, because there are other components that they may lack in terms of their sexual life, and one of these is adequate arousal to non-rape cues, and you can actually measure that by the same gadget, present the individual cues depicting mutually enjoyable sexual experiences with a preferred partner, and you'll find that some, not all, but some rapists don't have adequate heterosexual arousal. That seems kind of paradoxical, since rapists rape females usually. But you'll find that some rapists actually do not get aroused to mutual enjoyable sexual cues, and they need a treatment that will allow them to become aroused to women devoid of the aggressive cues. What it means then is, with this particular component of treatment, if you're dealing with a rapist who lacks this arousal, early in treatment he'll have minimal arousal to females. And we have a number of techniques now, and they've been available for some of them 10 years, to increase heterosexual arousal, so that over time, if you were plotting percent of erection, over time you'd find that the individual then develops arousal to mutually enjoyable sexual cues. Treatments like masturbatory conditioning, biofeedback, classical conditioning, something called fading, technique called exposure. All of these methods are currently available for increasing arousal to non-deviant cues. The third component, at least the third component that appears to be consistently a problem in a lot of rapists, is what are called heterosocial skills. You might call them heterosocial-heterosexual cues, because they appear to exist along a continuum. On one end of that continuum, you'll find rapists who lack even social skills, interacting socially with anyone, male or female. A little further along, individuals lack the ability to communicate, sit down, flirt, talk with, ask the girl out for a coke date, and what have you. You can find that out by setting them in a room, presenting them with a scene. Here's a girl you've never met before. I'd like you to act as if you are going to get involved with her, find out her name. You ask the rapist to carry out that activity. You'll find that some, not all, but some of them fail miserably. They fall flat in their abilities at relating heterosocially, heterosexually to a female. Now we have a number of treatments that can rapidly bring about adequate heterosocial skills in rapists. It's called role-playing. You actually bring an individual into a room with a female of an appropriate age. You ask him to practice certain scenes. And when he fails, you point out, 1, where his deficits lie. 2, you encourage the areas that he's done successfully. 3, you have yourself or another male carry out appropriate heterosocial skills with the female. You may actually videotape the rapist's interaction with a female and present that back to him and show him where his deficits and assets are. And then you ask him to carry that out again, that same behavior. They carry out the role-playing scene again, and you go through the same process, giving him feedback as to where he succeeded, feedback as to where the limitations are, ask him to improve in one small area, ask him to carry out that activity again. And we actually have a scale now for rating heterosocial skills. So, at the beginning of treatment, with some but not all rapists, you'll find that their degree of appropriate heterosocial skills is very low. And as treatment progresses, if you continue your measurement of this particular skill and your treatment is effective, you can find that with appropriate role-playing, you'll find that the individual develops appropriate heterosocial skills. I think the problem with the treatment of rapists is that for too many years we've not really attended to this problem. The reason for that is that the legal system gets involved, appropriately so, with rapists, and they're shuttled to non-psychological, non-psychiatric treatment modalities, incarceration and what have you. Our experience has been in measuring such individuals post-prison stays. We find there's essentially no change in their arousal patterns, no change in their heterosocial skills. You would kind of expect that when we incarcerate rapists in an environment where there are no females. Even the skills that they had that were appropriate heterosocial skills fall by the wayside. They're not used in that environment. There is no specific treatment to decrease their arousal to rape. We found that these arousal patterns sustain themselves in one case 20 years after the individual was incarcerated. And the treatment really can't be provided in this environment. It looks as if we're going to do anything about rapists, we're going to have to get some kind of treatment that can be carried out on an outpatient basis. Now that may sound a little controversial at first, but I'd like to give you the percent across this country of rapists who are actually incarcerated. 13%. That means out of 100 rapists, 13% go to jail. That means the vast majority are back on the street. Until that situation is altered, if it can be altered, I think we need some type of treatment program that will attend itself to the vast majority of rapists who are on the street. We need a program that can bring treatment to this particular group. Once again, I'd like to reiterate that all rapists don't have each of these problems. What we'll find is that some rapists have high degrees of deviant arousal to rape cues. We'll find that some lack adequate heterosocial arousal, not all of them. So we need to assess the individual, find out where he's at. If he lacks heterosexual arousal, then he needs to develop that. If he already has that, you're wasting your time to provide a treatment in that area. We find that some rapists lack heterosocial skills, not all. If we assess that individual before we begin treatment, we can identify that particular individual who needs the treatment. If the rapist already has those skills, he doesn't need any treating in that area. Lastly, I'd like to say I don't know if we can really discontinue treatment assessment. That is, I don't know if, given the current state of the art, if it's really possible to say, you're cured. You've been treated, you're cured. I think that's quite premature at this time. Our own program, we don't stop treatment. We may stop treatment at this time, but we continue assessment over months, years, in order to give some degree of protection to the environment. If we find that deviant arousal has come up again, it's rather easy to implement treatment again at that time. But I'm just saying I think we ought to be very cautious about handing out a certificate that says you are treated, you no longer have to be seen, don't worry about this problem anymore. I think we have to keep our options open.
Rape may be defined as sexual intercourse by use of force, fear, or fraud between individuals of the same or opposite sex. Rape has been called the easiest crime to accuse or charge, and the most difficult one to prove. Some countries in the world do not allow the charge to proceed without what is called corroborating evidence. Heterosexual rape is defined in the law as penetration of the penis beyond the introitus. Whether ejaculation occurs or not is irrelevant. An impotent man is unable to commit rape. That's why many of us may be asked if a person has had too much alcohol and you can prove that he is impotent or he's on, say, some Mellaril or whatever. He may not have been able to go forward with the charge that has been made against him. He may be able to commit carnal knowledge, sexual assault, or other minor forms of sexual offense, but rape implies a potent male with an erect penis. Oral sex is not rape, neither are indecent touchings or assaults. In the law, rape is seen as a serious offense, and penalties are quite high, ranging from probation, in rare cases of aggressive rape, to life imprisonment or even the death penalty in cases of misogynist rape in the South. In some jurisdictions, the term aggravated rape is a classification which includes rape by force with a deadly weapon, or when the victim has been harmed or assaulted in addition to being raped. Gene, I was concerned about 13% of the rapists not being in jail. Does that mean they're not currently in jail, they don't go initially to jail, and are they the aggressive or the statutory rapists? That's just a question I'm going to ask you for later discussion. Statutory rape refers to the unlawful intercourse between a male over the age of consent and a female under the age of consent, which may vary from state to state, from 14 to 21. Yesterday we heard Erwin Purr talking about the 50 different kinds of legal systems we have in the country, and more because of the federal jurisdictions. And the same is true in rape. It depends on where you are if you're at the age of consent. The male of 18, for example, has intercourse with a girl age 15 and the age of consent is 16. The intercourse is consensual, but the man may be held for statutory rape if the girl or her parents wish to press charges. This type of rape is not usually seen as a deviation, except when the age range is excessive. And then the deviation is referred to as pedophilia. Joe Peters has a definition of that back in Philadelphia. If the age range is 10 years or more between male and female, no matter what the age, or if the woman is under the age of 12, no matter how old the man is over the age of consent, it would be called pedophilia in his classification. One of the great difficulties in prosecuting rape is the cooperation of the victim, who has to be examined by a physician to prove that there has been a penetration or evidence of semen at the time of the complaint, or evidence of bruises or other physical damage as a result of the assault. Often the victim encounters a negative attitude by police and others who examine her, questioning whether she enjoyed it and testing to see whether she succumbed to temptation or was actually forced into a sexual act. Again, in Philadelphia, Joe Peters and others have been studying the effect of rape on the victims, whom they study at Philadelphia General Hospital, and are now developing a set of objective criteria for evidence of rape and credibility of the victim. That's a very big problem in the law, by the way. Credibility. Can you use a lie detector test? Some do. What other objective criteria must you find? What's the difference between consent? Is there resistance? Is there submission?
This is the end of Side A. More by Dr. Saddoff and his fellow panelists on Side B. This is Side B, Audio Digest Psychiatry, Volume 5, Number 16, continuing this clinical profile of the rapist, with Dr. Saddoff's legal classification, followed by a roundtable question and answer session moderated by Dr. Rada. Here now, Dr. Saddoff.
Usually the rapist is a one-timer, using poor judgment or forcing the issue under the influence of alcohol or drugs. At other times, he is a repetitive, aggressive individual who has a pattern of reaction that is uncontrollable for him. And occasionally, and often rare, the less homicide are those who rape and kill the victims. This type of behavior often occurs with a prostitute, where a deviant seeks a prostitute in order to kill her to prove that she is evil and he is the servant of goodness and morality. Women may be arrested for rape, especially if they help and conspire by aiding a male to rape another woman. The law has begun to change the name of rape to that of sexual assault, of which rape is but one type. Rape is a more difficult term to apply to both sexes, and thus sexual assault may be a more appropriate term in the law. In 15 states, laws were proposed to restrict and limit the testimony concerning a victim's sexual conduct prior to the assault. Recently in Philadelphia, a judge was criticized because he asked the victim whether or not she was a virgin. He did this ostensibly because the rape occurred in the man's apartment, and there was some question whether she were more sexually promiscuous and was hollering rape when in fact it was consensual. However, most people feel this is an irrelevancy to the crime charged. Most of the proposals in the legislature prove that such testimony should be restricted to acts committed with a person other than the accused. Most acts of legislation follow the pattern of the more comprehensive reform, barring practically all such testimony. In Minnesota, for example, and I'll quote, "Evidence of the complainant's previous sexual conduct shall not be admitted, nor shall any reference of such conduct be made in the presence of the jury except by court order, and only to the extent that the court finds that any of the following proposed evidence is material to the fact at issue, and that its inflammatory or prejudicial nature does not outweigh its probative value," close quote. Laws that stipulate that no corroboration be required of the victim's account of sexual assault were proposed in 5 states, becoming law in 3, New Mexico, Texas, and Washington. In Kansas and Wisconsin legislatures, laws are in the works which, if passed, would allow for prosecution of sexual assaults between marriage partners. At a recent APA meeting, Masters and Johnson fame suggested that sexual relations between a male therapist and his female patient, whether consensual or not, is coercive and should be prosecuted as rape. Frobisher quotes the Kinsey study in defining a sex offender, quote, "as a person who has been legally convicted as the result of an overt act committed by him for his own immediate sexual gratification, which is contrary to the prevailing sexual mores of the society in which he lives and or is legally punishable," close quote. That's a beautiful quote. Rape is an aggressive sexual offense. I have elsewhere divided sexual offenses into the aggressive and the anonymous, trying to show that there are offenses in which the individual does not wish to get close to or relate with the victim, but gets increasingly further away from the victim, such as the frauteur, through the exhibitionist, the voyeur, the obscene phone caller, the letter writer, and the fetishist. The aggressive sexual offender usually includes the rapist, the sexual assaulter, the lust murderer, some forms of pedophilia, and sadomasochism. There are some sexual deviations, this is getting a little bit afield, but I think relevant, which are not sexual offenses, such as coprophilia, transvestitism, and fetishism, unless one has to go out and steal the object of the fetish. There are some offenses which are not classified as sexual, but have sexually deviated underpinnings, such as arson, kleptomania, and some forms of burglary. I'm also interested in what was said about the extension from exhibitionism and voyeurism to rape, and I don't think we can ever predict when that's going to occur, but I have made statements in print, and I'll repeat them here, that the sexual offender is more of a specific psychodynamic individual than we give him credit for being, and I don't think we ought to label people by their behavior, but by their psychodynamics, especially when we're considering DSM-III, and that I think the burglar, in most cases, or some cases, more apt to become a rapist than an exhibitionist. I enjoyed the term that you used, Park, sexual entry, because I think sexual entry says it all in terms of the burglar. Sexual emission may not have to occur in terms of rape. However, an occasional suggestion may be found that emission must be established. Perkins comments on that critically. If the theory back of this idea was pressed far enough, it might reach the point of recognizing the effective use of a contraceptive as the complete defense to avoid prosecution for either rape or carnal knowledge of a child. The essential element is penetration. A wife who refuses to have sexual intercourse with her husband cannot appeal to the law that she has been raped because her husband overcomes her resistance with force. If, however, her husband helps another man to rape her, he can be convicted of rape. A husband who attempted to force another man to rape his wife was convicted of an assault with intent to commit rape. If the female consciously consents to the act of intercourse, however tardily or reluctantly, and however persistently she may resist for a time, the act is not rape, provided she is of such an age and condition as to be capable of giving a valid consent. The important distinction lies between consent and submission. The latter does not preclude a prosecution for rape. Submission to force or as a result of being put in fear and terror is not consent. Even in 1670, Sir Matthew Hale, Lord Chief Justice of England, said, quote, "It is true, rape is a most detestable crime and therefore ought severely and impartially to be punished with death. But it must be remembered that it is an accusation easily to be made and hard to be proved and harder to be defended by the party accused, though never so innocent," close quote. Intercourse with a woman who is so intoxicated from alcohol or drugs as to be incapable of consenting is rape. While intoxication is no excuse under the law for criminal acts, nevertheless, where the crimes require a particular state of mind with respect to the act committed, intoxication might constitute a defense. unlawful sexual intercourse with a female who is so mentally ill or mentally retarded as to be incapable of giving legal consent is rape. The issue here is obviously one of consent. In general, a disability must affect the ability to know the nature and consequences of the act so that she is not capable of rational consent. The use of fraud to obtain sexual intercourse may lead to prosecution for rape. Impersonating a woman's husband or pretending to be a physician may be elements of fraud. It is legally possible for a prostitute to be raped. Her unlawful career has not placed her beyond the protection of the law. If her only grievance was that she was not paid, that is not rape. I want to close with this statement that I have made many times, and I will repeat, I'm sure, many times, and that is that, in my opinion, rape is an aggressive offense, and that the rapist is not an unattractive man who could not have sex if he desired in the way that most men do. He does what he does because of needs that he has, as you've heard, and that if a woman is confronted by a rapist, she ought to recognize the danger that she is in, and I don't think she ought to give consent, but submission under the fear is not consent, and the person would still be punishable by law as a rapist.
Okay, well, that's a brief overview, and now I'd like to open it up for questions and comments.
Start with my question.
Well, the question was what percentage of individuals go to prison or are found guilty of rape. And in Memphis, there's 570 rapes a year, thereabouts. About 4% of those are false accusations and are clearly identified as false. So if we throw those out and consider the rest to be 100%, if you then calculate what percentage of individuals who have been charged with rape, that is, Mrs. Smith said, John Eldridge raped me, police go out and arrest John Eldridge for rape. If you take a look at the percentage of such individuals who have been arrested for rape, in our town, 15% are convicted of rape. The national average is 13.3%. So what I'm saying is a very small percentage of individuals charged with rape are ever incarcerated for rape.
As a request for comments on what factors in society account for the increase in reported rape, and I think the way I phrased the question indicates part of the answer. There's been so much attention to rape in the last 5 years that there's reason to believe that the barriers to reporting a rape have been considerably reduced. I think that the women's movement has done a great deal to encourage women to report rapes, and it's clear, I think, that one who has been raped and who reports that will find considerably more sympathy among her peers than she would have in the past, since it's become such a political issue. I think there's less of a tendency now amongst at least educated groups of women to feel that a woman who has been raped is, in fact, a covert participant in the crime. And I think it's easier now for women to report. There's no reason to think that reports are comprehensive at this point, however, and the estimates a decade ago of what percentage of actual rapes were reported varied from about 25% being reported to 10% being reported. And the increase that's been observed is nowhere near a 4-fold or 10-fold level. So there's a long way to go. But I think changes in reporting probably account for part of the increase in reported rapes. On the other hand, there may well be an actual increase in rape, and I don't know that there's any way that we can measure that at present. And so it would be out of place for me to comment on why something happened when we're not sure if it has.
The question is, how are we conducting the treatment? It's on an outpatient basis. What's the attitude of the rapist? We only treat individuals who say, I have a problem of being a rapist and I want to do something about it. And what that means is that we are getting a selected population of individuals who enter treatment. I think it's kind of important to point out that many rapists see themselves as rapists, as in tremendous need of treatment. They feel extremely guilty about their behavior. They just don't know what to do about it. And they're seeking treatment, but in the past there's been no treatment available, so where do they go? They go someplace, they say, I need help, and they find out there's nothing there, so they stop going. Once our individuals enter treatment, dropout is extremely rare. It's an extremely rare thing that a rapist who has once entered treatment will drop out of that treatment. Now, we'll lose a lot of individuals from the point of assessment to entering treatment. That is, a lot of individuals will drop out in the course of assessment, or we'll drop them out because they say, well, this was a mix-up, I really am not a rapist, and we'll shake their hands and say goodbye, and instead concentrate on those individuals who are seeking treatment. But once they enter treatment, given our selection process, dropout is extremely rare.
One member of the audience at this discussion posed every woman's question, should she resist the rapist, as so many articles recommend, or is resistance as dangerous as the recent study documenting rapist murder implies?
I can comment on that by use of a dramatic technique that I saw on television, which I thought answered it all. There was a women's lib group saying, resist the hat pin and whatever other stick you can use and you can get these guys, in one segment, and then they juxtaposed that with a convicted rapist in a prison who was being interviewed and would say, if only she didn't resist, I wouldn't have had to kill her. And then you go back to the women's lib, you women must resist and you must fight these men off, we've got to maintain our integrity and so on and so forth. Then they flash back to another convicted rapist, if only she didn't resist so hard, they wouldn't have had to hurt her so badly. Again, you can resist to a point, hollering or screaming or whatever, but then recognizing that your life is in danger, and then the priority is what choice do you make? When it comes down to you're alone with that man, he's stronger than you are, and there may be no other way but to submit. Not consent, but submit.
Gene?
I think the data you're talking about came from Denver, and there's one death per 904 during a 2-year period, one death associated with rape. So we're talking about a pretty low frequency of mortality with rape. I don't think there's one answer to what the woman should do. I think there's a series of answers, and the individual should start with the simplest procedure and the least dangerous and proceed onward. The victim should. I think initially she has to escape, throw her belongings in all directions, and run towards light, towards people. If that is unsuccessful, I think the next step is to clearly verbally resist. No question about it, assertive, no, under no circumstances are you going to rape, get out of here immediately. If that is not successful, or if the individual is carrying a weapon, I think the third step would be to establish a relationship with the individual, to attempt to empathize with him, to learn his name, to learn what his dating pattern is like. Now that may sound rather foolish, but it does establish a rapport between the rapist and the victim. If that fails, then I think the individual has to decide on the basis of what is the likelihood of her being killed or dangerously injured, what is the likelihood of that compared to her feelings about the invasion of her body. I think only the victim can make that decision then, how much she physically resists.
I must comment on that again. Two things. One, Gene, is that morbidity is also to be included as well as mortality, and we may have had only one death, but how much damage is done to the individual. And secondly, my experience in talking to the people who have been raped, is that yes, I knew those things, and if only I could think under pressure, but that as soon as he approached me, I froze and I could not do anything else. And this I hear more commonly than the few times I've heard how successfully clever the woman was to escape. And I think that's great ideally, but how do we teach people to act rationally in a panic?
I think you teach them by skills training, by presenting them situations where they have to defend themselves and respond in these various means. I think that's an excellent point. You can't just tell people, now here's what you do, because exactly, what you describe is what happens. I think it has to be accompanied by training.
Good.
Park?
In an effort to establish rapport with a potential rapist, I think the woman has to be very careful not to be condescending and maternal. If there's anything true about the psychodynamic theories of rapist behavior and the suggestion that rapists have been from families with seductive and yet sexually repressive mothers, I think that the worst thing one could do would be to take this man who's sexually aroused and then be condescending and sexually repressive toward him.
You remind me of a great story about a woman who was 70 years of age and was always very active and sprite and everything else, and going along. She lived in Center City in Philadelphia, and over the advice of her kids who said, you must get out of there because you'll be hurt, she lived alone. And one day she went to lock her door and a hand pushed the door open and said, get out of the way, I'm coming in, I'm going to rape you. And she got very frightened. And he twisted her arm and he led her up the stairs and marched her into the bedroom, and he threw her on the bed. He says, all right, now take off your clothes, I'm going to rape you. At that point, her fear changed to anger. She put her hands on her hips. She says, young man, you must be out of your mind to want an old woman like me, an attractive young man like you, and you could have anybody you want. He started to cry. Maternal, whatever. And she said, come on, don't take it so hard. She patted him on the back. Let's go downstairs and have a cup of tea, and we'll talk about it. Well, he just fled. She was lucky.
I just would like to add one other comment to that. This question comes up all the time, and I have asked a series, in one of the studies we did, a series of rapists, after getting to know them and talking with them personally, now, what would you have done in the event that the woman would have resisted? And each time I've done this, I've come out with about a 50-50 split. between those that said, I think that if she would have shown any kind of actual resistance whatsoever, I would not have gone through with it. And others that said, I think if she would have shown any kind of resistance or more resistance than she did, I would have hurt her physically. And some of those, although I think a small percentage, as Gene says, would actually go on to murder. Although I think Bob's point is very good, the morbidity is also very high. Now, the one that I know of recently in the last study we did, he was an example of one who did not have a weapon, and the woman resisted very strongly in her own apartment without an escape route, and he strangled her.
Well, about 30% out of Denver, 30% of the attempted rapes were stopped by what the victim herself did.
You know, I think that this is an easy area for us to focus on, but I think that this is, very difficult, except maybe in the sense that Gene's saying, if you could take everybody in this violent society and train them for these kind of situations, when faced with that, what do you do? In my experience, it's always been anecdotal. Of the rapists that we've studied, I've asked them, and I have frankly never put this down and tried to see if there were different demographic variables or different aspects to the actual crime itself. Because the question obviously would be, from Gene's standpoint, is this verbal behavior, is this actual behavior in terms of the potential dangerousness?
I have a comment about that. If I only had so much money in order to prevent rape, I'd treat the rapist who rapes at a high frequency. I wouldn't treat the gang rapist, the individual where the frequency is pretty low. I would select out the few individuals who rape 30 to 100 times, and I would put my efforts in that area. I think from a psychiatric point of view, we really are more adept at helping that particular individual who rapes at a high frequency, where rape is very much a part of his sexual arousal pattern. The individual who rapes in the context of other types of assaultive acts or within the culture of the gang that he lives within, that individual is less sensitive or responsive to what I know about our current psychiatric treatment modalities.
I think that all of us would agree that there is no such thing as a typical rapist, and there is no stripes or a scarlet letter or anything else that identifies these guys when they come up. And in fact, this is something that, in my experience in Albequerque, I'm constantly asked about, is when they have a series of rapes that they cannot find the rapist who's done it, they'll call and they'll say, well, what kind of a guy are we looking for, And the problem is that it could be the guy living next door. Now, one of the things preventively that I think we don't do as mental health professionals often enough, and that is that I think that there are many rapists who know about the fact that they are going to become rapists, or who have fantasies about this much earlier than what is frequently suggested, even in the literature. The youngest one that I can remember, as an example, was a rapist who told me that the first time he knew he had an impulse to rape, he was 9 years old. Now, what he remembers about that is that he didn't know exactly what it was he wanted to do, because he wasn't even fully aware of the mechanics of intercourse or the rape itself. But he knew he had this kind of a feeling. And what he actually did was, he waited outside in a parking lot for a female that he had seen in the neighborhood, an older woman, and got into the back seat of her car with some vague sense that he was going to do something to her. And she got in the car and she looked at him and saw this 9-year-old boy and said, "What are you doing in here?" He got frightened and said, "Oh, I got in the wrong car," and ran away. And his comment was that if only somebody along the way had gotten a hold of me and asked me, and of course you can turn around and say, well, why didn't you tell somebody? But, that's it. Secondly, that many of these fellas have had a history of voyeurism, peeping Tom, exhibitionism, etc. And some of them are caught, but they're never asked for some reason about these fantasies. Nobody ever says, have you ever thought about raping a woman, or, any kind of a sexual history? And some of these guys got dismissed with kind of boys will be boys kind of attitude. And they knew doggone well that they weren't typical or normal. But they themselves were not ready to volunteer. And some of them have told me, if only that psychiatrist or if only that probation officer had asked me when I was 14, this might not have happened. That's one thing I think we can do, at least as professionals. I don't know what techniques, but certainly we are missing the opportunities we've had. We've done studies using the MMPI and some other personality inventories and have found a number of things. Usually, of course, sociopathy scales high on the MMPI, and very often depression scales high. These scales may change as time goes along. One interesting thing we did a study on the alcoholism of rapists and found that 33% of the group that we studied were alcoholics, and that 50% had used alcohol at the time of the commission of the offense. So we did a study of the MMTI to see whether or not there was any difference, and we could find absolutely no differences on personality measures between those who were alcoholic and those who were non-alcoholic in terms of rape. There is one group, is it in Alabama, Gene, that has developed a profile based on certain psychometric tests?
Well, you're probably talking about Stan Brodsky, who's at the University of Alabama, Tuscaloosa. Actually, he's done some work trying to look at preventative measures, actions that the victim can carry out to prevent an assault on herself, and has presented rapists with a variety of different scenes or role-playing situations and quantitated. I guess he's published that in a book called Sexual Assault this year, looking at some possible ways that the female may respond. They also have a rather active group down there dealing with the assessment and evaluation of rapists, rape victims.
I can tell you that in terms of the classification that I gave you, which was just a clinical one that I found useful for testifying in court and for dealing with preliminary aspects of disposition of the rapist, that you will find certain MMPI patterns that are more characteristic of one type than the other. And in fact, at Atascadero, one of the people there did do a study comparing these and found certain patterns to be more consistently associated with certain types of rapists. Gene wants to comment.
We already have a means of separating some. We can separate the pedophile by presenting pedophiliac cues, and this individual will get a generalization gradient that shows greatest arousal to young victims. So you can split off that individual whose treatment needs are somewhat different than the rest. We're also able to separate scientifically the more dangerous sadistic rapist. We can actually present scenes of assault, no sex, just assault, physical assault, and measure the individual's erection response. And the sadist, if he's a good sadist, is going to generate a lot of erection response just to assault. So we can separate out that individual currently using the available scientific methods we have.
Gene, isn't it true that that tends to be a very small group?
That's only about 15% of rapists, but we're talking about the more dangerous individual, if your criteria for dangerousness is a greater likelihood of physical damage to the victim, or if your criteria for dangerousness is a higher proclivity to select very young victims.
I'd like to comment on the experience in Baltimore with publicity for treatment programs. At the University of Maryland, Dr. John Lyon has been running for a number of years a violence clinic, and the early publicity associated with the opening of that clinic attracted a great deal of interest, and I think they're still finding that they have more patients applying and being referred for treatment there than they're able to accept. Similarly, at Johns Hopkins, Dr. John Money was involved in publicizing a program for the treatment of sex offenders called Help Before the Sex Offense. And what they're doing is taking patients who are volunteering for treatment, screening them very thoroughly with an extensive sexual history. I believe this screening interview takes 3 hours. And then accepting for treatment people who have not yet been subject to any criminal sanctions for their sex offenses, and who are willing to engage in treatment in which they either receive Depo-Provera or a placebo in conjunction with group therapy. And that group has been running for a couple months now. There isn't any evidence yet on its success. But my point was that they had plenty of volunteers, and they really did have to screen to try to see who they'd be able to treat.
We haven't advertised too much, quite frankly, because of the political concerns. Well, if you ask 10 people on the street whether they feel rapists should be treated or hung, I think 9 out of 10 will say hung. Most people in our society believe that if we just send these individuals to prison, everything is going to be okay. And that's not the case, but I think our society believes that. So when you offer a treatment program, you get a tremendous amount of resistance. At a grassroots level, there's a lot of resistance to treatment of rapists.
When you're talking about prevention, I think you have to talk about prevention of recidivism, because otherwise you're getting into behavior control before anything ever happens. And is that a genetic control? Is that sociological control? Is that ethnic kind of control? I think if you get a rapist who has been and you lock him up for the rest of his life, that'll solve the problem for him. But if you let him out, then you've got other problems.
We've only seen a couple individuals who haven't been in contact with the law We're dealing only with individuals who are not currently involved with the law, however. That is, they're on no charges. We're treating individuals who are voluntary, seeking treatment under no coercion from the courts whatsoever. We have an HEW grant, so we're not allowed to use any prisoners or anyone where the court has ordered or demanded treatment.
We've dealt with it in Albequerque by having an outpatient program which was approved by the courts, by the judges, and has close liaison with our state prison. We send counselors up to the state prison prior to any rapist's discharge and establish contact and get involved with him and try and work on that kind of a transition. And that's been reasonably successful, although I will say this, we are always waiting for one of these guys to go astray, and when he does, we know that our funding is potentially in danger. And one of the problems with that is that you're always going to be very, very conservative, and we are. Our outpatient treatment program doesn't take any but the best risk. We have worked out a combination where two people, male and female, do go and run a group, and the most likely to succeed group gets started in a therapy program prior to discharge.
And with those comments, we conclude this issue of Audio Digest Psychiatry, a bi-weekly service of the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This program is copyright 1976.